Welcome Dr. Priya again. And this time she'll be talking about ECMO, a very popular topic with us.
Thank you very much, sir. It's always a hard act to follow, Sheila, so I don't thank the organizers for that. But my next talk is on ECMO and the guidelines associated. I've chosen to go with adult respiratory failure and VV ECMO because clearly it's a massive topic and I can't do it justice in 20 minutes. And we've already talked about VA ECMO a little bit in the previous talk. So similarly, I'm going to go through some case-based scenarios and build the guidelines into that. And I'd like to do that by answering a few questions like who, when, where, and how we do ECMO. So clearly we're battling time, so I've selected a few relevant clinical topics like the indications and timing. I won't be talking about cannulation strategies, cannulation selection, guidelines around equipment, etc. But I will be talking about circuit-related management, a little bit about medical management, and something about weaning as well. For the reference, I've used the ELSO, the International Society Guidelines for Acute Respiratory Failure, which were updated last in August 2017. Unlike the previous talk, a lot of the guidelines are really don't have strong evidence, and as you can imagine, in this group of patients and ECMO, the studies and randomized control trials are few and far between and difficult to do. And I've also incorporated some of our local guidelines as well. So again, a couple of cases that we've seen in our unit. The first one, this is a 16-year-old boy who was from one of the South Pacific Islands who referred to us for ECMO as we are a retrieval center. Presented to his local hospital with dyspnea hemoptysis in the context of a current leptospira outbreak, deteriorated quite quickly, requiring intubation ventilation, but ventilation was really difficult and he got worse and worse with increasing hemoptysis, multiple transfusions, and they called us up requesting ECMO retrieval. So again, we'll go to a multiple choice question here, which relates to indications for ECMO. And if you could have a look at that, a patient with the following condition is likely to have the best outcome following VV ECMO support. Again, no clear right answer, but could you call out what you think might be the answer? So I've gone with that one, and I'll tell you why. That's a pulmonary cause of ARDS, which is likely to benefit from ECMO if it's severe enough. The first one is an extrapulmonary cause of ARDS, which tend to do less well. Infective exacerbation of COPD, okay, but I guess we need to know that how bad the COPD is and whether there's any reversibility. Bronchopleural fistula, again, it's an okay indication, but the patient has adenocarcinoma, which is likely to be associated with its own poor outcomes. And the last one, this patient has now been intubated for 10 days, and that group of patients is less likely to do well if they go on to ECMO after that period of time. So I've put it in a bit of a traffic light type pattern with the better indications up above and the less good indications below. Pulmonary embolism I have in brackets because those patients usually have circulatory failure as well, so they need VA ECMO rather than VV on its own. So those are the ones for hypoxemic respiratory failure that I have. So when would you put these patients on ECMO? I find the guidelines less helpful for this. They suggest it should be considered if the mortality risk is greater than 50% and indicated if the mortality rate is greater than 80%. And it's hard to know how you work this out, but they've given criteria with PF ratios, lung injury scores, not something that we really find useful in clinical practice, I don't think. However, the EOLIA study that was recently published, their inclusion criteria are probably a bit more useful clinically. They used a PF ratio of less than 50 for greater than 3 hours, or a PF of less than 80 for more than 6 hours, or a pH of less than 7.5 with a PCO2 greater than 60. So that's a little bit more clinically useful, but I think it needs to be taken in context of the patient themselves, where they are in their illness, their comorbidities, etc. But I think the important part about this is that they should be having optimal care for their severe respiratory failure. And often enough, this is something that's not done well enough. And that includes things that have much more evidence base to them than ECMO itself, like neuromuscular blockade, prone positioning when possible, using the appropriate PEEP, keeping them dry, managing their RV failure and pulmonary hypertension when that exists, and treating the underlying condition. So those things really do need to be done before even considering ECMO, and ruling out immediately reversible causes. Being an ECMO retrieval center, all too often we get calls about patients who actually have things that really don't require ECMO and can be sorted out much more simply, and also by applying the evidence-based guidelines. You would be familiar with the Eolia study that was published recently in May of this year. And it suggested that in patients with severe ARDS, routine use of ECMO is not superior to waiting to and using ECMO as a rescue maneuver. Obviously, you don't want to leave it too late, but you can equally use it when further deterioration occurs. So that was the main conclusion of that study. So ECMO does have a role, but I think it really needs to be in the context of an overall package of managing severe respiratory failure in an evidence-based way. Coming back to our case, the patient was cannulated with an Avalon catheter, which is a bicaval catheter accessing blood from the superior and inferior vena cava, returning it through the tricuspid valve into the right ventricle. Long transfer by air ambulance, which was fortunately uneventful, and you can see his X-ray, chest X-ray there on admission to ICU. The patient ended up having a positive anti-GBM antibody, and Goodpasture's disease was diagnosed and was treated with steroids, plasmapheresis, and immunoglobulin. Long ECMO run, 25 days, prolonged admission in hospital, but eventually made a full recovery and was discharged home well. Moving on to our next case, this is a 21-year-old medical student who was actually from our hospital, who was previously well. There was this terrible dust storm in Sydney, and lots of patients came in at the same time. He called the ambulance and collapsed just as the ambulance arrived, and they intubated him, brought him to hospital. On arrival, he was very difficult to ventilate with high airway pressures, no air entry bilaterally in the context of a clear chest X-ray, so a diagnosis of acute severe asthma was made. You can see his ventilation parameters there. He was sedated, given neuromuscular blockade, treatment and second-tier treatment for asthma. And you can see his blood gas there, SATs of 95%. Big difference between the peak and plateau pressure, suggesting an airway resistance element with intrinsic PEEP as well. And you can see there's hypercarbic, mixed respiratory and metabolic acidosis on that blood gas. So that group of patients is really quite a good group if you really can't ventilate them and treat them appropriately, because you know asthma is going to be reversible and treatable. So those patients tend to do well. And again, here for hypercarbic respiratory failure, we have a traffic light type system for the indications that are quite good and those that are not so good. Acute airway obstruction, while you're dealing with a problem, ECMO might be able to bridge you through that. What about the contraindications? Now, these patients are in a very difficult situation, and they really don't have many alternatives at all. So all the contraindications are sort of relative contraindications. Certainly, as we said, people who've been ventilated for a long period of time already with non-protective ventilation are not going to do well. CNS hemorrhage, well, you can run VV ECMO without heparin at all because the risk of clotting is low. And certainly our Goodpasture syndrome patient had 25 days of ECMO with no heparin at all. And obviously if they have irrecoverable comorbidities, that's not somebody you want to put on VV ECMO. Where should ECMO be done? Now, there is some evidence that suggests that high volume centers definitely have lower mortalities than low volume centers. So if you do less than 6 annual cases per year, those centers tend to have a 40% higher mortality than those cases that do those centers that do larger numbers. And I think, as a number of people have mentioned, it's really a team sport when you're doing ECMO because it involves all sorts of people, and you need to have a coordinated, well-functioning, collaborative team with no big personalities, involving the surgeons, the cardiologists, perfusionists, etc. So I think it's really quite important to remember that because it's a big process of care that's involved with ECMO. How is ECMO done? So a little bit about the management, and I'll just show you a very short video there, and there's a question at the end of it, so don't fall asleep. So this is a patient going on to ECMO in our unit. And my question to you is, the patient in the video is most likely to have been cannulated for which of the following conditions? Powers of observation. Yeah, very good. So all the others are indications for VV ECMO. This patient was going on to VA ECMO because you could see a retrograde perfusion cannula going down the leg, and pulmonary embolism would need VA rather than VV ECMO. A little bit about managing the circuit in a clinical way. So there's only two buttons that you can fiddle with when you're doing VV ECMO. One is the RPM, which determines the flow, and the second is the rate of fresh gas flow that's going through the circuit that determines carbon dioxide clearance. So with the flow itself, full flow for a patient is somewhere around 50 mils per kilo per minute. And what we want to do is to use the lowest flow possible to maintain the arterial saturation of 80 to 85. But importantly, the ventilator should be at rest settings, otherwise you're losing the benefit of the ECMO that you're doing, because what you're trying to do is protect the lung from ventilator-induced lung injury. Like Sheila was mentioning before, what we're really looking at is the oxygen delivery, and that's what's important to the patient, which is be a combination of oxygen delivery from the circuit and oxygen delivery from the lungs, whatever residual lung function is there. And it relates to tissue oxygen uptake as well. Presumably our patients have a fairly static uptake. They're sedated and probably paralyzed at this point in time. Physiologically, the DO2-VO2 ratio is somewhere within about 5, so you've got quite a bit of a big buffer there. So we don't need to target it that high. You can have somewhere around 3, and that should be perfectly adequate. So physiology question there. The SATs we could run at 80 to 85, I said, but you might even go lower as long as the following two parameters are adequate. Anyone? Yeah. A, cardiac output and hemoglobin, because the three determinants of tissue oxygen delivery are arterial saturation, cardiac output, and hemoglobin. So if you can't get the saturation up, you can manipulate the other parameters if possible to try and optimize tissue oxygen delivery. Coming to CO2 removal, so we run gas through the circuit, which contains oxygen, obviously, and that's known as the sweep or the fresh gas flow, which determines decarboxylation of the blood, the rate of that flow. And when you're setting up your circuit mainly for oxygenation, the CO2 removal is way in excess of what you really need. And what we do is to titrate the sweep gas flow to maintain the PCO2 in sort of a physiological range. If you only want to do CO2 clearance, you need very little blood flow, and you can crank up your sweep gas flow to about 15 liters per minute, really, because all you're trying to do is decarboxylate the blood, and you're not worried about oxygenation in that case. So just coming to a troubleshooting question on the circuit, this is our patient with good pastures, has a saturation of 70%. Which of the following interventions that you do at the bedside will not improve this? Any takers? See, very good. All you're doing by turning up the flow rate of the oxygen is increasing decarboxylation. It'll do nothing to your oxygenation because you're running on 100% anyway. It's just the rate of flow that you're increasing. All the others would help you. A little bit about medical management of these patients. Managing the ventilator, one question to ask is, does this patient need a ventilator at all? Because you're doing all the function of the lungs through the ECMO circuit. However, in practice, if you've got very stiff lungs or the patient's very unwell, has multi-organ failure, they find it quite hard to manage being completely awake and breathing, even though the ECMO is doing all the work. So you may need to ventilate these patients, but ideally, it would be nice if the patient could be extubated. The ventilation should definitely be set at rest settings. We'll talk about that in a moment. And if the PCO2 was very high, you want to bring that down slowly. You also want to probably sedate them heavily in the first little while you're going on, but then try and come off or decrease the sedation as much as possible to facilitate things like spontaneous breathing, movement, etc., all of which we know are good for our patients. Maintain bronchial toilet. We do quite frequent bronchoscopies to achieve that end as well. Choose one of these which you think might be the most appropriate rest ventilation settings. I'll give you the answer in the interest of time. So the top one, you can see that the driving pressure is very high, the difference between the PEEP and the pressure control. So you're swinging between very high driving pressures. The second one, the respiratory rate is very high. So again, you're swinging very quickly between high and low pressures. The third one, high FiO2, not ideal. And probably the fourth one is the best rest setting that you can use. The hemodynamics, same if the patient was not on ECMO, because this is VV. We use echocardiography a fair bit to help us with hemodynamic monitoring and try and keep the patient as dry as possible to facilitate their lung recovery. One of the big Achilles heels of ECMO is the titrating or treading that fine line between bleeding and thrombosis. And both of these things happen regularly in ECMO patients. You can see a classic example there where bleeding is happening in the wrong place and clotting is happening in the wrong place. There's blood pouring out of the chest drains and into the bed, but at the same time, there's clotting of the backflow cannula, and that's quite challenging. Following is not a cause of bleeding in ECMO patients. My answer to that is heparin resistance. That's the only one that causes thrombosis. All of the others can cause bleeding as well. So there's processes that are going on simultaneously which favor bleeding and others that favor thrombosis. In the bleeding, one of the interesting ones is the development of the acute von Willebrand syndrome, which results from the shear stress and loss of the high molecular weight multimers of von Willebrand factor, and that makes patients bleed, as does hyperfibrinolysis. And there's a bunch of factors that promote thrombosis as well. And during patients' courses on ECMO, they swing between being quite procoagulant and then on the other side bleeding as well. I find it quite confusing knowing which tests to do to monitor these patients' hemostatic pathways. So I've tried to simplify it for you. These are the group of tests that we use to test heparin action. You don't need to do them all. We use the APTT. The anti-10A is probably the best, but is expensive and has a turnaround time, but can be done as well. We only do antithrombin 3 if the patient appears to be heparin resistant and is requiring very high doses of heparin to increase their APTT. So those are the ones that test heparin effect. These are sort of the standard tests for coagulation, which we would do every day. We have a bit of an interest in these viscoelastic tests in ECMO patients, but we use them in ECMO patients who are bleeding. So we use ROTEM, and we have an algorithm which is goal-directed, which tells us what products to give, because you want to stop the bleeding, but at the same time, you don't want the circuit to clot. We also need to look intermittently for effects of hemolysis on the circuit, and those are the tests you would do for that. And there are a number of tests that are coming up that are in the experimental phase, but I think these are the main ones you would use, and they are talk about them in the ELSO anticoagulation guideline. Just the last bit about weaning. So weaning from VV ECMO starts from the time that you start ECMO, because you want to plan right from when they go on how you're going to wean the patient. And when the underlying disease process has been taken care of, and you think that the patient's ready to wean, the recommendation suggests you decrease the flow in steps right down to 1 liter a minute. If you're using a sweep FiO2 of 100%, we use a sweep FiO2 of 100% because we don't have a blender. But if you do have a blender, you might want to decrease the flow to maybe 2 liters a minute and decrease the sweep FiO2 at the same time. And if this is achieved, if you're managing to maintain reasonable saturations, we would turn off the sweep gas flow completely. You don't want to stop the flow because the blood would clot. So you just have venous blood circulating without being oxygenated for about 12 to 24 hours. And if the patient's okay, we would decannulate them at that point. If the PCO2 stays up, and that sometimes happens, oxygenation recovers before CO2 clearance, we would keep them on low flow for a longer period of time till the CO2 part is resolved as well. So with that, I thank you for your attention.
I request Dr. Nadkarni to felicitate Dr. Priya Nair.